Good afternoon, everyone, and welcome to today's IFAM webinar. I'm Ron Ackermann, and I direct the Institute for Public Health and Medicine. Before I get started today, I want to remind everybody that we encourage all members of the listening audience to submit questions to the presenter at any point during the presentation by using the Q&A button on your Zoom screen. At the end of the presentation, we'll move through the questions in the Q&A with time permitting, and we'll try to answer as many as possible. Please don't use the chat function for questions, as we don't monitor that regularly throughout the presentation. I'm both excited and honored today to be today's IFAM webinar presenter. As I said, my name is Ron Ackermann. In addition to serving at Northwestern as the director for the Institute for Public Health and Medicine, I also serve as co-director for the Chicago-wide Center on Diabetes Translation Research and have worked for about 20 years in the area of policy informing research in the area of chronic disease prevention and management, specifically apply evidence-based interventions, usually behavioral interventions in primary care and community settings, to improve the prevention and management of chronic conditions such as diabetes. Today, I have the pleasure of giving a presentation that I've titled Pragmatic Research Designs, Replicable Intervention Strategies, and Enhancing the Generalizability of Findings. The presentation, as I will start now, focuses on some examples I wanted to share from our research in our team here over the past 15 to 20 years or so. I wouldn't say that we've developed, and I'm not here today to present to you novel theories or frameworks that we've used in the research, but I do believe we've, through a multidisciplinary team-based approach, have combined a number of methods from fields of implementation science and econometrics, as well as behavioral research, in unique ways to try to advance research that is really fundamentally designed to inform sustainable interventions in primary care and community settings, largely around diabetes prevention, as well as a focus on scaling. So I wanted to talk about two key themes: how we've adapted evidence-based interventions with the goal of sustainment and scalability, and how we've designed the research to advance that in the hands of stakeholder partners. So I'll begin by focusing on these, sorry, I'm advancing here, on these two areas, what I'm calling pragmatic intervention design, which is taking efficacy proven intervention strategies that it might be theoretically grounded in high fidelity and fitting them into busy, practical, real world settings in ways that attempts to preserve their fidelity, but make them more sustainable and potentially scalable. I'll say a few words about our experience in this area and just some key themes that I think are important to this type of research that might benefit others doing similar work. I'll then turn and spend the rest of the presentation describing our combination of methodologic approaches to try to design research in a way that is informing replication and scaling. And an important theme of that is generalizability of the study population and its findings. So I'll talk about what we've learned in that area and then end with discussion. So I wanted to start with drawing upon the RE-AIM framework and how we sort of think about our research to inform scalable implementation of evidence-based, what are usually health system or other delivery system type interventions that involve professionals that might have to perform other roles or responsibilities or essentially behaviors to try to deliver some services that might then in turn reach individual patients or clients or community residents with education and support to try to improve chronic disease care or prevention. So we begin typically in our work with efficacy research, so drawing upon clinical trials and systematic reviews and clinical practice recommendations that show that something can work and does work if delivered in a high intensity way, usually in the context of an efficacy trial. And then we want to say, how do we apply that in the real world and design a research program that will inform, firstly, understanding, can it still be effective in the real world, but also, can it be delivered? And if so, how? And what is needed for professionals or health systems or community organizations to adopt new interventions or strategies or services that have emerged from something like a clinical trial? If we do that, do the evidence-based treatments reach the intended target audience? If they do they reach those who might benefit most? Do they reach all groups that might benefit equitably? And in the RE-AIM framework, we call those two dimensions, adoption and reach. We then are interested in, can evidence-based treatments be implemented with fidelity? And how can the implementation be made routine in a busy real-world delivery setting? So I'll talk a bit about that and how we rely on trying to understand what the essential fundamental components are of the interventions as they're developed and studied in efficacy research. Those are the things we might not want to change if we want to retain the fidelity, but how we also identify the things we can change to improve fit and sustainment. So I'll talk a bit about how we evaluate and consider those approaches. And ultimately, does the adoption and the fidelity and the effectiveness change over time? And is it financially sustainable? If it has costs, meaning different tasks or roles or use of resources by delivery organizations, whether it's a primary care clinic or a community, is there a way to recover the costs? Is it sustainable through existing incentives or payment systems? Or are there other ways that it provides value that make it sustainable? And then finally, what is needed to spread or replicate these approaches in more settings? How do we understand that process? And how do we fundamentally design the interventions from the beginning with the goal that they, if we understand what can be adapted, and how to fit it within busy delivery systems, we can understand more about where it can be replicated and how to replicate it. So I'll talk more about that and fundamentally how we've tried to design research to answer all of these questions in one or two, or as quickly as possible, but one or two studies rather than 17 or 19 or 21 years. So scalability has been defined a few different ways, but I just want to kind of define it for those that don't really think about this much. And it's been defined as the ability of a health intervention that was shown to be efficacious on a small scale or under controlled conditions to be expanded under real world conditions to reach a greater proportion of the eligible population while retaining effectiveness. So as we think about how we want to approach pragmatic intervention designs, I think it's important as researchers that we understand what our role is. What we're fundamentally talking about is taking something that was developed based on theory and in a very controlled way, often tested in an efficacy trial, and we're trying to put it into the real world in a way that really must be delivered by staff and personnel and practitioners who aren't researchers. We often think we have wonderful ideas after being involved in the developmental work or in the clinical trial. We may know best because we're on the recommendations committees nationally, or we read all of the journals and know what's emerging and what frameworks and theories were used. But ultimately, it's not the researcher who will deliver the intervention when it's at scale. And it really is important from the beginning to realize that you're designing something that somebody else must own. And that can't be for just the period of the grant or the effectiveness trial. It has to be a lasting commitment. So fundamentally, what you're implementing has to be something that has deep investments and a commitment by the delivery organization and those who will deliver it. What you can sort of bring to the table as a researcher is that external knowledge and experience. If we work over years trying to understand what works well and what doesn't, even in the process of working with stakeholders to develop interventions together or to put them into practice, there are very strong frameworks and descriptions of kind of a lasting scientific approach to maybe approaches that will work better, or frameworks that give us important dimensions of what we should always be considering or thinking about. And we can bring those to the table, but the choices ultimately aren't necessarily made by the researcher. It's really the process that you bring. The other thing is, as we sort of collect data, analyze and interpret it together with stakeholders, our goal is to generate generalizable knowledge. And sometimes when we look at changes in a particular setting, the actors in that setting, the implementers or the leaders in a particular system might be interested in, did care get better? Or did the patients like what we delivered? Were they satisfied? Are they more likely to use us for their care in the future because we're delivering better services? But ultimately, we also care about answering questions like, would those same individuals have felt the same way if we'd have delivered a different intervention, or if we'd have kept doing what we're already doing? So we're very mindful as researchers about causal effects and interpreting patterns in the data that we observe. Is it really due to the putting that new intervention into practice, or could it be due to other secular trends that are happening or other changes that are happening at the same time? And what we bring is a wealth of knowledge about how to really be cautious about interpreting data to draw the right conclusions about whether we should keep investing in this new intervention or whether we should focus on the other things that are maybe helping the system to improve over time. So we should bring our rigorous research knowledge and how to make comparisons and think about and interpret data. People with a lived experience, those who are providing care on a daily basis, the staff who perform the roles that you're asking as part of an intervention in primary care in a community, the people with the health condition really are in the best overall position to recommend, select, and evaluate implementation strategies and outcomes. So we can't do this work without stakeholders. We have to be mindful who they are, how to engage them, and how to make decisions in a collaborative way that really isn't just solely drawn from what our last research study showed or what our framework might tell us to do, but rather to meet in the middle, where we really are talking about what's sustainable and what is going to be something we can continue to do within that delivery system across time. So if we're trying to do an implementation or deliver an intervention pragmatically in a way that is going to lead to sustainment and scaling, there are a few things to be mindful of. Oftentimes we come and say, well, this is the evidence-based practice. There's this clinical trial and the NIH spent $180 million on it. So shouldn't we be doing this? It's the right thing to do. But if it's unclear to the implementers, whether it's the leaders of a health system or a health payer that decides what services get paid for, or the employer that helps an employee purchase health insurance and pay for the funding month by month, or it's a community organization that might be delivering an intervention, if it doesn't make sense why that evidence-based practice is better than what they're already doing, or it's unclear to them whether it's an advantage to offer the change, it's not going to be sustainable. So you don't want to be in a scenario where you're convinced that it's the right thing to do, and you've made it, for example, very easy for the implementing system to do. You've made a very simple intervention out of it, but they really don't fundamentally buy into why this is happening, or don't understand why it might be that making the change is going to be advantageous to their organization or the clients they serve. The other thing with respect to scalability, when we make the change in the system, a lot of times early on in a lot of implementation science studies, we invest a lot of resources into the research team supporting the implementers in a very specific way, preparing the system, making structural changes, doing trainings and education, monitoring the results continuously and feeding them back. If we don't have a off-ramp to making sure that those types of preparation, training, and monitoring strategies can be sustained by the implementers or by the implementing system. If it's not consistent with what they're doing in other areas, or it always requires a lot of external training and support, it makes it less sustainable and less likely to be scalable or replicated. And then finally, a lot of times, and I'll talk about this briefly, whatever they're doing now, they're doing because it's favored by the current incentives. We see patients one by one in primary care. I saw patients this morning in my primary care practice, and the health system is reimbursed based on the amount of time and complexity of that visit. It's based on a one-on-one transaction of me spending time with those individuals, and that's how the health system gets paid. It doesn't necessarily get paid if I phone the patient later this evening and talk about their lab results after the visit, or spend a little more time in between visits trying to connect them to a community program that might help them eat more healthfully or find a safe place to walk in the community. Those things might value or benefit the individual, but there aren't currently incentives or rewards within the system to do those sorts of things. So if we're asking individuals in a health system or in a community setting to perform new behaviors or roles, we have to be mindful that if those activities aren't supported by incentives and rewards, and not all rewards are financial, but if we can identify or align with incentives and rewards, and in fact, if the status quo is more favored, we're going to be fighting a losing battle. So things that are easier to sustain and scale have the opposite characteristics. The implementers view advantages over the current standard or current status quo or whatever they're doing now. The implementers can prepare and train themselves or with minimal support or maintenance, and that the new implementation strategy is aligned in a way that it can be favored or supported by existing incentive and reward systems. And so that's something to always be mindful of as we design as sort of fundamental overarching principles. As I said before, I can't tell you how many times we've entered and begun talking about a way to do something rather complex in a real world setting. And the first thing we often think of as researchers is how can we make it as simple as possible? Because the simpler we make it, the more sustainable it will be. Although that's not necessarily wrong, by itself, something that's simple is not necessarily feasible or scalable. It's the same analogy in cost effectiveness. Some of the most cost-effective strategies are costly. Cheaper things are not necessarily cost-effective. So it's just more complicated. It's not as if keeping something simple might not be a good approach, but diluting down an intervention strategy or minimizing contacts or changing the sort of intensity of an intervention may not ultimately add value. It may erode the fidelity of the intervention, and in the end, it may not make it more feasible or scalable. So I'd encourage people not to fall into that trap. One analogy is just simply some simple task like, hey, put the book on the top shelf. But when we realize the bookshelf is 10 feet tall, we need to think about, well, how do we put the book, which maybe is a new service or new intervention or evidence-based practice, into that sort of system that seems to be ready to receive it? How do we reach the top shelf? And that's really the implementation strategy, right? We can think of it in a simple way. How do we get something into the system? How do we put it in place? How do we get it there? That's really adoption. And how do we sort of get it to stay there is sometimes a little more of a trick. But that's the simple perspective of implementing something in a system that maybe is ripe or prepared to receive it. As I said, the book must remain on the shelf and not be prone to fall off. So that's where the sustainment issue comes in. But again, like that's too simple of an understanding of the problem or a conceptualization of the problem. And it's important to think that rarely does the book fit where you want to put it. And the system may be designed to support other types of interventions. And I'll use an example in a moment, but this is a depiction really drawn from the CFER framework. And it's really that every intervention, the purple on the left is sort of a depiction pictorially of a multi-component intervention strategy. And there are the core kind of foundational components of that, the things you never want to change. They're the theoretical grounding or basis, or something about the intensity that gives it its fidelity. And then there's the issues of who's actually doing the delivery, and simple things like, does it have to be delivered in a research lab, or can it be delivered in a primary care office? Can it be done as a group instead of individually? Can it be done virtually through, a telephone or video link or other measures? And, those sort of changes in this format or channels sometimes don't change the core components. We call that the adaptable periphery, and we might modify the strategy that was used in the efficacy trial to fit the shape or the sort of resources or the capacity or the incentive and rewards of the system. So the notion there is to kind of reshape or resurface or change slightly the things that we think are adaptable to improve fit but not change fidelity. We can also change the system. We can restructure, prepare it, do things differently. But again, the more disruptive that is, the less it might be replicable, the less it might be something that we can scale to other delivery systems. So we need to be mindful of both our approaches that we use to improve fit, and again, drawing on the perspectives of stakeholders to inform both what is adaptable and also how to make the adaptations both to the system and the intervention to improve fit. Now I want to go back to my bookshelf analogy, because no bookshelf or no system is empty. We can't just throw the book on the top shelf. There are other books there already. And I want to pose, not for the first time ever, but just to all of you, to be mindful that if you're trying to put an intervention in a busy delivery system, whether it's a primary care workflow or whether it's a community organization or elsewhere, a system sort of continually evolves over time until it's sort of trying to maximally use the resources it has. Everybody's working 100% or full time, their plate is full. We don't know which activities can come and which can go and what the value might be. But we now have a full bookshelf, and our task is to implement something or to place a book on a shelf when there's no room. Theoretically, we might say, well, the way to really deal with this is to take all the books off the shelf and really fundamentally go back to the drawing board and say, what's the goal and what's the best way to achieve it? Let's take out all the books we don't need and let's restack them and organize them in a way that makes the most sense and is the best, most efficient way to achieve our goal. But we can't stop a busy health delivery system to do a wholesale redesign. Often that's very difficult to do. So we think more about what book can we remove from the shelf to make room for our book. Oftentimes we don't even think about this, but it's important that the current usual care or standard of care is something that the system is already doing for a reason. We have to understand why they're doing it, how it came to be, what incentives and rewards are supporting that. And even if we think it's a low value service, we actually have to de-implement or remove that before we can implement or put our book on the shelf. So it's really important that before you start to design an intervention for pragmatic delivery or real world delivery, start with really like, how are you achieving this goal now? What services are, what behaviors, what activities are you performing to achieve the goal? How did that come to be? What incentives are in place to continue doing what you're doing now? I saw patients one-on-one this morning because that's how, and I didn't, call them afterwards yet. I haven't talked to them. I haven't done the things that I might think might be good for their health because, I'm doing the things that the health system is structured to do and designed to recover payment for services. And that's the reality. So why is the system that you're working with doing what it's doing, and what incentives, what, either financial or non-financial incentives are in place to continue doing that? Have you before considered making changes in the way that you achieve that goal? What have you considered and why? And who decides that? Is that an annual thing? Do you use a strategic plan? Do you meet monthly? Who makes the decision? Is it somebody in the practice? Is the person who does it, or is it somebody outside? What information is used when they make the decisions? So we've actually learned to ask all of these questions, and really sort of that informs, if we know how the current status quo came to be, we can understand better what the on-ramps are to developing an implementation design for our new intervention or our evidence-based practice. And we can also consider the strategies or barriers we'll face in removing what is currently there if that becomes necessary. If we fail to consider de-implementation or the removal of the existing approach, that also can be a fundamental barrier. I'll move on from there and give you some examples from our own work, just to kind of give it a little more texture. So a lot of our work, as I said earlier, has been in diabetes. Current statistics in the United States are that 36 million Americans have diabetes. 29% are older adults, and it's more common in people who identify as racial and ethnic minorities, or who live in communities that are disinvested or have really low resource community areas. What we need to be mindful of, and we've begun to be more mindful of, is that beyond the 36 million who have diabetes, another 96 have elevated blood glucose and sort of early signs that they may have insulin resistance, which is the precursor to diabetes. And in longitudinal studies, about 10 to 20% of those people, those 96 million, would develop type 2 diabetes over the next 5 or 7 years. It's about, by CDC's prediction, about 2 million per year annually develop type 2 diabetes in the United States. There was a study that was conducted 20 years ago called the US Diabetes Prevention Program. It's been replicated in other countries as well. But it basically did a rigorous efficacy trial to say, can we prevent type 2 diabetes in people with high blood glucose or people with insulin resistance? So it used an efficacy trial design, and it used it compared 3 interventions: brief education, which seemed to be the standard or usual care. Now, a lot of the patients don't even know they have it and don't get any education. But in the trial, the control or comparison group, everybody got some education that they had the condition, and that healthy lifestyle changes might help them prevent developing diabetes. One group was randomized to receiving a daily or twice daily diabetes medication, or a glucose lowering medication, metformin. And the other was given a resource intensive lifestyle coaching program. So a high contact behavioral intervention where people were basically encouraged to set a goal for about 7% weight loss. And they were, developed an individual action plan on how they would reduce their calorie intake and increase their physical activity to achieve the weight loss goal. They got one-on-one coaching support weekly for about 26 weeks, and then it moved to bi-weekly and then monthly, but it never ended. It was longitudinal coaching support. It cost about $1,500 per person to basically to have the staff and the resources to meet with those individuals and provide that coaching and other interventions over the first year alone, and then $700 a year thereafter. So it was a high intensity lifestyle coaching intervention. And the punchline was that that coaching intervention was the most effective, and it lowered the relative risk of developing diabetes about 58% beyond the control group getting brief education. So if you roll that up to kind of a macro level, for every 100 high-risk patients, the DPP, the average age was about 50. So for every 100 high-risk patients at about age 50 on average, if you give them and deliver a lifestyle intervention for 3 years, in the way that the DPP did, you can prevent 15 new cases of diabetes, 162 missed work days, avoid the need for any blood pressure or cholesterol pills in 11 people. There was an avoidance of 91,000 in healthcare expenditures for other things related to usually the development of diabetes, but other health conditions as well. And then it added the equivalent of about 20 perfect years of health. So we all thought, who wouldn't want this? This is something we would want to do. And if you apply that to the 2 million people in the United States developing diabetes each year, if we delivered the DPP to all 96 million Americans who are at high risk, we could expect to prevent more than half of those, or prevent 1 million cases of diabetes a year. So from a federal or social perspective, it's something that we definitely would want to explore. How do we get this out into the real world? So the questions we thought of is, can this be delivered outside of a research trial? And if so, by whom or where? How would we identify the eligible people? Because in the efficacy trial, there were rigorous methods to find the people with abnormal glucose tolerance. How would we do that in a real world setting? If we offered it in a real world way, would people take part? Why or why not? And does offering the DPP in that sort of modified way or an adapted way have the same benefits? Maybe it has some harms that are new because the population's different. What does it cost? And then as we thought about it and thought about delivering an intensive coaching intervention that targets people with a high blood sugar, we knew that we would need, if we deliver this in the real world, we would need a strategy to identify and engage the people who would benefit. We need a delivery system for the intervention, a delivery system that really saw itself as wanting to, promote health and prevent disease, had a capable workforce, that has really people that do already focus on health education or behavioral change, and had some infrastructure for putting an intervention into practice and doing it kind of consistently across national networks or national organizations. We also we knew that there would need to be alignment with incentives and rewards because the DPP intervention has real costs and complexity to it. So we can't just expect this to happen without alignment of incentives and rewards. We would need to take the RCT intervention and adapt it to fit in a real world setting. And we need a strategy to prepare whatever delivery system was doing this to implement it sustainably. We then want to show that it was successful because who would believe it if we didn't show that after making all these changes and targeting a slightly different population, that it still worked. So we focused on the core components of the DPP. They were a modest but achievable weight goal, plans and coaching support that focused on both diet and physical activity. There was a behavioral underpinning that focused on self-monitoring and self-regulation and supportive accountability from that coach that led to problem solving and the development of self-efficacy. We also knew that there were some other studies that were happening where they tried to deliver half as many contacts with the coach. And really the fewer the contacts you get, proportionally less behavioral change and less weight loss success over time. So we knew we couldn't stop the intervention and we didn't think cut the number of visits in half. But we focused on things like delivering it in a lower cost setting and with lay instructors who were trained similarly, but maybe were paid at a lower wage and in a lower structure of support. And we tried to consider doing it in possibly a group rather than individual or one-on-one format. We worked with the Y because it has a national delivery network and it's present in about 10,000 communities in the United States. And we made those changes over time, iteratively and collaboratively with the YMCA organization and wellness instructors and administrators who work within the Y. We used a variety of tactics, and I'll just summarize over time because in the interest of time, I do need to move on, but we learned that the Y of USA, which is kind of a national support organization for local YMCAs like you see in neighborhoods of Chicago, There's a national enterprise that doesn't own or operate the local facilities, but it facilitates the local Ys to offer structured programs. And there was an example of an arthritis aquatics program that was developed at Stanford and actually disseminated in a rather structured way throughout Ys in the United States. And we were able to learn how that worked and what challenges it faced, and where it kind of fell down in a couple examples. But it taught us that there was a delivery approach for scaling interventions that had fidelity and needed monitoring. We also collaborated to define some instructor competencies, so things that were important in the DPP trial for instructors, but we designed a training approach collaboratively with the YMCA to train wellness instructors to attain those competencies, but remain wellness instructors and employees of the Y. And we delivered that in a 2-day training and eventually added a refresher training that was done every 6 to 12 months. It focused on, basically behavioral coaching and things like motivational interviewing techniques, but also updated things like professionalism training that the YMCA was already doing. So it fit within the current training and competency structure that the Y used for wellness employees. We incorporated an expanded set of research outcomes. So we were interested in, if we do this in the real world, do people come? Is it delivered with high fidelity, and do people lose weight and improve things like blood pressure and sugar? But we learned that the Y wanted to know, if we were offering this to non-members, did anybody join the Y? Did they have other benefits? Did they like the Y? Did they see the Y as a resource in ways that they hadn't before? And they also wanted to know some different things about implementation, as simple as, whether the wellness instructors were behaving in a professional way that was consistent with the YMCA's principles. So we combined those and measured them and fed them back to the Y during our research. And we learned that the Y has this culture of like health seekers, right? It's sort of, when people are ready, they join the Y in January and they give programs to those individuals. But now we were going to be referring people who weren't members and didn't know they had a problem and were being sent to the Y to get help. And we had to kind of struggle together on how the Y would do that. And we knew that they were already thinking about strategies to engage with local health systems. And we built on that. We tried to kind of develop their interests and understand what it is they needed to learn to know whether that was a good strategy for their organization. So all of these things helped us to design pragmatic and scalable intervention strategies collaboratively with the Y. We published on the process of how we adapted and pre-tested and trained wellness instructors. And I think it's important because, again, getting back to our role as the researchers, publishing on what's generalizable knowledge and how it can be replicated is really important to the process of advancing science. And I think this helped other groups to build on our work and to take it in other directions and other types of delivery settings. So before we end, I just want to say a few words about our research designs. And I'm going to move rather quickly because I took a little more time talking about the intervention work. But I want to talk just briefly about what's different about effectiveness trial research and efficacy trials. And I don't want to belabor this, but in an efficacy trial, we're asking the question, can it work? So we design very high fidelity interventions, and the researchers control the delivery of those interventions so that everybody assigned to them receives them with high fidelity. And we carefully select volunteers to participate in the study on the basis that we think they'll finish the study and behave well and receive the treatment and finish the research measures. That way, if we have a negative result, it's sort of definitive. We did everything we could and it didn't work. So a negative study is the definitive kind of end moment for an efficacy trial. In an effectiveness trial, we're asking, will it work similarly when we put this into a real world context? We're actually interested in representative eligible people. So in the DPP, for example, we identified individuals with 2 stages of glucose testing that had to be repeated over multiple visits. In the real world, we might look for people that have been diagnosed by their physician or that have a different type of test we do more regularly in primary care or in a sort of busy delivery setting to identify high risk. And we would use that as the definition of high risk in a pragmatic sense. We would try to study the whole population instead of only volunteers. And the real world staff and practitioners would deliver the intervention, and the people being offered the intervention would take it up at whatever dosage they would. And that's the sort of real world dose, and their adherence is the real world adherence. And a negative study is actually a learning opportunity, because we'd say, aha, it didn't happen in the way we expected. You know, and what we would want to do, I'll breeze through this because my next slide addresses this, but in the efficacy trial, we picked the people to maximize benefit and minimize harm. And volunteers is one of the steps in an efficacy trial. If you imagine people that can navigate the multiple steps of volunteering and completing screening and baseline visits, they tend to be upwardly mobile, high literacy, high trust in the health system, health seekers. And those people might do better anyway. So we're anticipating out in the real world that people aren't going to do as well, and they might stumble, and we might want to learn something from that process. And you know, to use an example here in the DPP, 100 we did at 27 recruitment sites. We did PSAs and targeted mailings of patients in the health systems, and 158,000 people called the recruitment centers. And, you know, a chunk of those people, about half or 80,000 of them, eventually were found to have BMI outside of the target range. They weren't overweight or obese, or they didn't have a blood sugar that was elevated. But the remaining half, out of 75,000 who weren't ineligible because of those kind of eligibility requirements, but they basically were excluded because they had another condition, hypertension, you know, a little bit of angina, heart disease, things that a lot of people have. Maybe they had depression, maybe they had other conditions that were exclusions in the DPP. And another half of them because they just didn't have interest. So we excluded 95% of the potentially eligible people. And in the real world, we wouldn't be doing that. We would be including those people and offering them the services. So those people might have more harm. They might have different benefits. We might want to be prepared to study that. We should expect that they might be less adherent. They might benefit differently, and effectiveness might be different. But we want to study that whole population, because that's the reality. We don't limit to volunteers for research in the real world. So, you know, when we design an effectiveness trial, we want the study population to reflect all who might be offered. How do we identify prediabetes in a real world way at a high volume in a sustainable way? And that's going to be the eligibility criterion for the study. And we don't want to then exclude many people based on, you know, other conditions or their inability to navigate research measurement or volunteer simply. So we've had to design our studies in very unique ways to try to allow this to happen. The things that I was referring to earlier when I said it is a learning opportunity when we find a negative effectiveness trial is partly because the population's changed. It's possibly also because maybe the intervention delivery was less intensive when we adapted it. Maybe when it's delivered in the real world, it's not consistent, or it's not sustained over time. Maybe the engagement in the intervention is low. In the efficacy trial, we control it and everybody gets it when we're assigning them to it. In the real world, people choose whether to engage, and they might leave the intervention prematurely, and engagement is low. They don't complete it to, you know, the full dose. They don't get the full intended effect of the intervention. And maybe the target audience that we've essentially included here is less impactable. Maybe they live in community contexts in which it's more difficult to make behavioral changes, and we need to understand that. So we will need to evaluate these scenarios or these likely possibilities as we expect to see lower effectiveness. There's a few different ways in which effectiveness trials are conducted. Many in the implementation field have begun to advocate for what are called effectiveness implementation hybrid trials. And those are simply trials where we have aims to do both, to measure effectiveness and to measure implementation. But some of those focus more intensely on researcher controls for the implementation strategies and do include very limited populations and very intensive research measures. So they're not always necessarily pragmatically designed. A pragmatic trial tries to use an intervention that's being delivered in real life routine conditions, usually by real world delivery agents or staff or practitioners. And then we try to use existing data sources instead of dedicated return research visits where people do intensive biometric assessments and blood draws and surveys, because that limits participation in the types of people we can collect data from. So we tend to use existing data like electronic health records or claims data to identify the outcomes if it's feasible. And then we tend to use an encouragement trial design, and I'll talk briefly about that and why it's advantageous. But instead of randomizing people to receive an intervention, we randomize people to be encouraged to use an intervention. And then we're able to observe who uses it and understand why and why not. And that gives us an idea about the reach or the engagement in the intervention by different population subgroups and overall and across time. And we can study the overall effect of offering the intervention because we've randomized one group to receive and one group to not receive encouragement. But we also can creatively study those who get the treatment. And I want to come back to that in a moment. So in the efficacy trial framework, again, we seek volunteers, we collect informed consent because we're going to do very intensive measures, and sometimes the interventions themselves are potentially have different benefits and harms, and so we need to disclose that and get written consent. We do a run-in to make sure that the people are adherent to the treatments they're assigned to before we start it, and then the researchers deliver the interventions. We might monitor fidelity, but we don't necessarily monitor the implementation in quite the same way. Whereas in a pragmatic effectiveness framework, what we try to do is to compare two strategies like a scalable intervention approach for something like the DPP to usual care. Both of those interventions could be delivered now. They're not inherently risky or harmful. And so unless we ask people to do very intensive research measures and biometric assessments and surveys, and we have no direct contact with individuals in the study, we actually don't need to collect informed consent. So it removes the need to disclose that they're being randomized to different types of advice or being offered different services while we study this. And it removes, it allows us to study, the entire population. And while we do that, we can study on top of that, the adoption, the reach, and the implementation of the intervention strategies. And we can look at the entire population, not just volunteers, so we can understand, is it representative, is it replicable? Are there inequities in the way people use or receive or benefit from the intervention designs? I'm going to move rather quickly, but one of the unique things that we do here, and I'm just going to jump forward to one last point that I wanted to make, is that if you want to understand, if you randomize people to being offered treatment and you want to understand not just the effect of offering treatment, but the effect of receiving treatment, you have to realize that people chose this. And people who choose or can navigate to get to the treatment or the coach, that might have travel, that might have literacy, that might have navigating the community sort of implications. They might be more likely to be health seekers or health trusting or higher literacy or more preparedness or readiness. And those are conditions that might be related to the outcome. So if we look at treatment receipt and the outcome, it might be we're just seeing that, people that are likely to do well regardless have better outcomes. And we're really not understanding the effect of treatment. We'd like to eliminate this source of confounding. So the way we do this is with an econometric technique. This is the sort of encouragement trial design, where we randomize to being encouraged and not encouraged, and people choose to engage or navigate to be engaged in treatment or not. Sometimes even when we don't encourage treatment, depending on how the treatment's delivered, some people might actually get it. So there are people who engage in treatment even when they're not encouraged. And what the economists have figured out is that the overall outcome of the people in each randomized treatment group is really the weighted average of the outcomes of all of these groups. And if being randomized to being offered an intervention doesn't affect an outcome, like weight loss, except if you go to treatment, and the only treatment difference here is what we're offering, then people who get the intervention are going to have similar benefits, and people who don't have the intervention are going to have similar benefits in both groups. The one thing we have to be mindful of is that this group who takes the intervention when it's not been encouraged is this group that just is going to engage no matter what you do. They're just prepared and activated and ready. And that same subgroup exists over here somewhere. We assume that it's the same size because we've randomized people. The probability that you're an always compliant person is the same in both sides. And the probability that you don't engage if you get encouraged, you're never going to engage no matter how we offer it, is the same in both sides. What we're left with is these two leftover groups. It's the same proportion of each arm, and they achieve a different weight loss effect because one group got the treatment and one didn't. And this is the treatment effect we want to estimate. And we do that using an econometric technique that we've begun to use relatively regularly. And I won't have time to talk about this, but we've used this in a variety of studies where we're able to estimate both the effect of treatment like we would in or randomization like we would in a randomized trial, and the effect of receiving treatment in a way that isn't biased. We've been able to show that treatment effects are larger and costs are often larger in the group that takes treatment. But we can estimate things like the cost per pound of weight loss, or the cost per visit attended, or things like that that are really important from an implementation perspective. We've also applied this to transitional care, which is a way to kind of provide a medical home solution to people that leave Northwestern's ER or inpatient setting who don't have a primary care medical home, or don't have insurance, or are homeless. And some people that are offered transitional care when they leave the hospital use it, and some people don't. So we've looked at the cost effect of offering it and of receiving the transitional care intervention, and shown that it's actually cheaper for the health system to offer this intervention to individuals. And we've shown that if people, for example, that receive the transitional care intervention at a time like 180 days, even after you account for the added cost of the intervention, the total cost at 180 days for the whole health system is a savings of $15,000. So offering proactive coordinated care to people without a medical home actually saves, because it prevents inpatient readmissions and other problems. So we've been able to use this technique to validly estimate costs and outcomes in ways that have helped implementers decide whether to sustain and ultimately replicate or expand these types of interventions. So I'm sorry I took that much time. I wasn't seeing anything popping up in the Q&A, so I wasn't pushing to get to questions. But I hope that today you've seen or understood a bit of how we sort of try to combine aspects of the RE-AIM framework into novel sort of hybrid effectiveness trial designs that use an encouragement trial framework to study a whole population. And I think that that can be used in a variety of different ways. It can be used to study multiple different formats of, you could use not just two arms, but multiple encouragements that might reach different groups in a different way. You might combine, you might be most interested in how we get people to the intervention. So you might have multiple encouragement arms. You also can design very large trials using administrative data sources that look really fundamentally at if there's differences based on social characteristics and social determinants of health and the way people access these types of interventions or their outcomes. So I think it's a flexible framework. And if you're interested in talking about these more, learning more from members of our group, or trying to apply it in your own world, I would just encourage you to contact me by email. So I really appreciate the ability or the opportunity to share some of our own work and some of these design sort of nuances today. I'm sorry I went the whole time, but I didn't see any Q&A, and I appreciate that that you all were interested in attending today, and I'd encourage you to reach out if you're interested in how we did this, or maybe talking through how you might apply these sorts of methods in your own work. So thank you so much today, and I'll give you back the last 2 minutes, and want to thank you and encourage you to see you in next week's IFAM webinar. Take care.